Start recording.
Did he start the broadcast already?
Yeah. So we're live right there, right, Juanita?
Let's say.
Josh, you started yours. Both of them, all three of the things.
You want like where you're on? Awesome.
Diana, is that door closed? Yes, thanks. Are we all ready? Yes. There's that. Okay. You good? Ready? All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast number 199, Sub-Symptomatic Post-Concussion Exercise. And then we're also going to be talking about a vestibular component. Our guest today, Dr. Samarat. Dr. Samarat has been on here several times, and she is one of the leading specialists dealing with concussions. And so it's always a pleasure to have her on here. Her expertise and just very friendly, personable person. Can you say that? Anyways, easy to talk to. There we go. And then Chris is my first time meeting him, but he's working here at the Ironman Sports Medicine Institute, working with the vestibular rehab. So he's developing the sports concussion management throughout the entire system. So it's going to be good. And I'll have some questions here at the end for you, Chris, specifically, because we have a kid that has been having a heck of a time trying to get his vestibular therapy done because insurance and all this other stuff. So hopefully we can get something streamlined, worked out, or at least you can give me some tips towards the end once we get to that. But I'm your host, Jeremy Jackson. Sitting right beside me, we've got
Daniela.
Joshua.
Juanita. Tiana.
and Tiana. If you want to join our conversation, sportsmedicinebroadcast.com using hashtag DSMB. That's where Destiny is right now on Twitter. And then the show notes, the links for this, once it gets posted, will be sportsmedicinebroadcast.com/Dr. Ott. That's DROTT, Dr. Ott. Sportsmedicinebroadcast.com/Dr. Ott. That'll be where this one is posted. This is number 199. Our very next episode will be next Wednesday, number 200. So it's a big celebration. We've got lots of prizes. We're having a 4-hour podcast. So it'll be live, so lots of people can jump in and out. There'll be 8 different guests over those 4 hours, 30-minute segments, March 2nd from 9 to 1 CST, Central Standard Time. And then the links for that are sportsmedicinebroadcast.com/NATM for National Athletic Training Month. National Athletic Training Month. Who's squeaking? All right. Juanita, who do we have joining us live?
We have Mitchell, Mickey Brown, Rob DeJohn, Carlos, Rachel, Callie, Utsi, Isra Montano, Jason Moore, Dennis Walker, Derek Cook, Joanna Reese, and Daniel Young.
All right, thanks for joining in. And as always, when you're in the live chat, have those comments there. Juanita will read them. And if it's a question that we can answer or we get to, then we'll ask them of our experts here. Without much further ado, Daniela's got our first question.
Dr. Ott, can you give us a brief overview of sub-symptomatic post-concussion exercise?
So historically, the approach for concussion management has been to rest, both from a physical standpoint and a cognitive standpoint. But over the past couple of years, there's been more focus on when is it appropriate to allow a concussed athlete to start exertion and how long should they wait before that occurs, and really what's the amount that's appropriate. So there's still a lot of unanswered questions, but some research out of the University of Buffalo, Dr. Letty led a group of researchers to look specifically at, could we monitor someone's heart rate post-injury and do some serial increases in their cardiovascular level of activity in a safe fashion and determine at what range an athlete would be able to work out, mainly just doing like treadmill, elliptical, things like that, work out within that range acceptably without having symptoms increase, and therefore give them a specific protocol to follow.
All right, so what year did you say that research started?
I believe 2012 was some of the first early publications. Now, to date, most have been done maybe with athletes who have been prolonged in terms of their recovery. So perhaps maybe they're months out from their concussion. What hasn't really been researched and what has to be investigated is, could we start doing this activity within the first few days of an injury? And that research has yet to come.
All right.
And when and where did this concept come from?
Thank you.
Yeah, so basically, with respect to this injury, as I mentioned earlier, it kind of started or spearheaded out of the University of Buffalo with Dr. Letty.
All right. So you said, are they currently working on the length of time, the days out? Is that what they're currently working on?
I think that they've certainly espoused to doing that, as well as other groups and other researchers who have similar interest in rehabilitation post-concussion. And really, to be honest with you, it's probably more of a individual threshold. I don't think we can apply, just like we can't apply the same types of management strategies to every athlete post-concussion. There may be athletes who need to start an exercise program maybe within 3 days, maybe some it might be more like 7 or 8. It just depends on maybe a lot of the characteristics that are going into the management and really the severity of their injury. So it's not as simple as it may sound.
All right. So on that note, kind of before we started this, you were talking about you're going to be hiring a research assistant. So what are you currently using? What are you collecting? What data are you collecting as far as heart rates and workouts and things like that?
So my research interests aren't solely directed on this topic area. I have my hands sort of in several different pots when it comes to identifying of concussion, prolonged recovery, gender differences, and so forth. So we have a number of studies ongoing right now. I think the one that's I'm most excited about that's coming forth is looking at females post-recovery and determining what is driving these lengthy recoveries in females. So we did get some grant funding from the Moody Endowment to be able to research this. So we're about to start collecting data there. We're really excited. But clinically is really where we use the topic that we're discussing today, the subsymptom threshold, is that we use that clinically for our management. And Chris Shields is joining us today. And so when we have athletes that we feel like are in a position to do this and they've been cleared by a physician to do so, which I do want to kind of get into caveats at some point too about when this would be appropriate and not, then Chris and his expertise as a vestibular therapist working with concussion can put these athletes through a program that's safe and controlled, and then therefore instruct them when they get home, or the athletic trainer involved in their care when they go back to the training room, on how to perform these things. So certainly we want to do some research in the future on this, but right now it's just more or less utilizing it clinically from what we've learned from research that's already been done in the field.
So what has been your impression of sub-symptomatic post-concussion exercise?
I think it's been really effective for people that are appropriate to engage in this type of exertion. It can be very helpful for mood, certainly healthy for physical health. It's good for brain health in the sense of cognition. There's been studies supporting that exercise is good for cognition just in general. I think that when athletes who've been deprived of doing physical activity and resting for too long, becoming sedentary is just a really negative thing for the recovery. So I think it's been really positive, and I think the outlook starts to increase. It looks positive when they start to engage in this type of aerobic activity.
All right, so again, obviously this is individual, right? You can't treat any two concussions the same, but in general, what are the findings there? And again, this is general. I'm not saying always follow this, but in general, they should not ever start these sub-maximal heart rate workouts until they've seen you and been cleared by you. Well, you a concussion expert, or is it that once we as athletic trainers see this and decide that? So what are your thoughts there?
Well, it might be a good idea before we get into that, just to really even describe for the audience what we're talking about here. I don't think we've had a good description about what we're discussing in terms of subsymptom threshold exertional testing. So Chris, would you want to talk about how the process, starts from, we can get into like who's a candidate and who isn't, but perhaps you can talk about, how do we assess this and what are the tools involved?
Yeah, so typically what we'll do is we'll bring a patient in, and once they've stabilized in terms of symptoms and they don't have the severe symptoms that they had right after concussion, we'll bring them in and we'll put them on the treadmill. And what we do is we set the speed at usually around 3.5 miles per hour, and we'll start slowly each minute increasing the incline of the treadmill. And what we're trying to do is slowly increase the heart rate. And so as we increase that heart rate, there's usually a level, which was, sub-symptom threshold level is kind of what we're testing. Where's the threshold at where they actually have a headache spike up at a certain heart rate? So we're trying to increase the heart rate, and there's a point they'll get to where the headache spikes, and that's what we call their headache threshold or their symptom threshold. So the goal for sub-symptom threshold training is to work out below that threshold. So a lot of times, say they get to 150 beats per minute on the treadmill test, and that's where their headache spikes, then we're going to usually start working out and do a progressive aerobic protocol at around like usually 60 to 70% of that.
right. So in your office, you do the testing. They are walking on a treadmill and gradually increasing their intensity, which increases their heart rate.
Mhm.
And then at whatever point they say, all right, my head is starting to hurt, or like, man, I really can't focus, or like, what's the indicator there for you?
It's purely headache, really. I mean, they'll oftentimes have dizziness and headache, but what we'll do mainly is we stop when they start having a headache. So really, once the headache starts increasing at all, that's when we say, and we're constantly monitoring. Sometimes you can see it on their face, sometimes they don't fess up, but you can see it as an expert clinician. So once the headache spikes at all, then we stop the test there. Because if you push into headache with concussion and concussion rehab, it's really thought that we're going to prolong the recovery. So we don't want to do that, obviously.
Gotcha.
Mhm.
Okay, so that gives us a good definition, which I'm sorry I forgot to include in the beginning. That happens sometimes. Okay, so then that would bring us to, is this something that we could do in the athletic training room?
Absolutely, yeah.
So,
Can I take that one?
Yeah, I think that when this information came out a few years ago and it's become more popular in terms of the benefit of exercise, especially in prolonged concussion, it's important that individuals still have to be seen by a physician, a concussion specialist, and they have to be prescribed this. So this isn't, I want to be very clear, it's not return to play. It's not doing the return to play protocol. It is doing a rehabilitation. Just like if we were to prescribe them a medication, it's something as a precursor to help facilitate recovery. So what we do is when the physicians, clear someone to do this, or we feel like it would be appropriate, and we have someone who's trained to do the therapy, when they're shown the therapy by Chris or someone within our clinic who has the training to do so, then we can guide the athletic trainer in the high school on how to work with the athlete in the athletic setting in terms of athletics or whatnot, and be able to do these exercises. But we're also having the athlete and the athletic trainer provide, almost daily or every other day updates, how they're progressing. So if there's anything wrong with it, or in the sense of the person's doing worse, or the symptoms are now increased or elevated, starting to interfere with the school day, then we can tweak it and begin to advise them accordingly.
So like Derek Cook, he's logged in. I think he said, the closest hospital is like 45 minutes to an hour away. I know he's got good repertoire with his team physicians there, but for someone who can't get to you guys easily, like you guys are, 20, 30 minutes away, maybe 40 minutes on a bad traffic day, does that affect the education? Like some of the places that you go, I know you went out to like Beaumont to educate people. Does that affect their ability to do this with athletes?
I really think that, again, this is something that should be carefully instituted. And I think that, if they can come for that one assessment and at least get, go through the whole thing and make sure that from a medical standpoint, they're even an appropriate candidate, that's really important. So again, I think there needs to be some specialist involvement and some team approach in order to indicate to the athletic trainer who would be appropriate to start this mechanism and who isn't. Because there are some who, even in a couple of weeks, if they're still very symptomatic, we still may not approach this with, because they're having a real hard time even just getting to school. So you got to just be really careful. And obviously y'all know your athletes better than some of us who see them on a one-time basis. But I think having more people involved to assess the person is the most important thing.
Gotcha. All right, there's a question from Rachel. She was asking, is the treadmill important because it has the jarring effect? Did you show that one either there? Yeah, the jarring of the athlete and the running. So not just a bike. Does that make a difference?
Hey, it does make a difference. That's why we start them on a walking test. So this is a sub-maximal graded exercise protocol. It's the bulk treadmill protocol. So, that's why you start at 3.5 miles per hour, not like 4.5 or 5 or 6. We don't want to start with running, because if you start with the running, the jarring plus that high intensity, it increases the heart rate a lot more quickly. So then the brain really can't handle it. So you're trying to see in a gradual sense, at what point can we, find where the heart rate kind of threshold is. So we'll use the stationary bike a lot of times for the training after we do that initial testing. So you can use the bike or the treadmill for that training, but we don't usually take them into a jog or a run, because the jarring itself will cause a headache oftentimes.
Gotcha.
So kind of testing on the treadmill first, and then if, in the athletic training rooms, if they only have a elliptical or, whatever, or something different,
Stationary bike, yeah.
then you're getting that initial heart rate done. And that's the way that the protocol by Letty and colleagues was initiated to follow, and then subsequent with some other types of means that's in the training room.
All right. So you asked me before in my post, I put out a picture of the watch that I have. Does it make a difference which heart rate sensors? Did they say specifically in that research, or just a heart rate sensor, or wrist only, or chest
I
only?
think their preference, if I recall correctly, was doing the chest heart rate monitor. But I understand, again, not everyone has that or the means. So we assess them first with that. And then we often will ask the families to get one, a wrist or whatnot at Academy. And so it'd be really nice if athletic training rooms had that, for this type of thing. So when, one of us come back to one of you as an athletic trainer and say, hey, I think this person would be great for this, then you have that in the training room to help them with.
Okay, so on that note, is there one that you recommend? One that's simple, that's maybe inexpensive?
Not necessarily. We use the Polar brand at our clinic, but I think the chest straps are typically more accurate than the one that measures it on the wrist itself. So if you want to be more accurate, then you get the chest strap. But really, as long as you have a pretty good, consistent reading, it doesn't really matter.
And sometimes it's a little challenging for some individuals for the chest strap, and based on body size. So you might have to have a couple of different means for assessing that.
And would it be beneficial, like this watch I wear all the time, or when I sleep, would it be beneficial for them to wear that chest strap throughout the day to monitor? Does that give you any extra information?
That's a really good point and question. I hadn't really thought of it before. I think that from a psychological standpoint, we spend so much time asking athletes, patients about their symptoms and kind of characterizing, did this help make you have a headache? Did this help you? And I almost feel that would be kind of more anxiety provoking than anything. And, people start to modify all bits of their day when we really want them at some point to start habituating and to gaining a threshold at which they are exposed to activity again. So I would actually shy away from that, I think, with respect to like thinking and just cognitive or other activities in general.
Yeah, I agree. Same thing.
Mm-hmm. All right. So obviously you're part of our concussion oversight team. If we want to incorporate this somewhere else, again, like I said, Derek's way out there, or, Rachel's in California, or Mitch is in Tennessee. So I don't have any idea what their concussion oversight rules are and team looks like. So what are some things that an athletic trainer might need to do to break the ice with this topic, or that kind of thing? Well,
yeah. And so it's tricky too, because we have the law in our state, which, all states have laws now with respect to concussion, but, ours specifically says removing an athlete from play and then going through a scientifically validated protocol, which that's somewhat vague, of course. But then the UIL, our governing body, has came forth and given sort of a set of guidelines indicating that an athlete should be completely symptom-free, at least for 24 to 48 hours before starting any kind of aerobic activity. So you can see that technically, if you wanted to get down to the semantics, this is going against what we really have in the UIL guidelines and the law. But the reason why I feel like we can defend it or be able to show its worth is that it's rehab. So it's in the sense that a physician writes the prescription for it, or it's ordered by someone that has seen the athlete and makes decisions with respect to return to play. So we have to be really careful about here. And this is where I've seen it mismanaged is, we've had people utilizing it for the benefit of, if we can get the person, exercising and they can do all these things, they're going to go back to play faster. Well, in some degree, yes, but it's, again, not return to play protocol, it's rehabilitation. And so it can't be mistaken for that. There's still a progression one needs to go through. And that's my only fear in doing this, is that it's misinterpreted. And I've seen some schools do that more kind of at the collegiate level, where it's maybe, people are rushed back and they haven't really necessarily followed this appropriately. So I would say that, training is important. Standardization is important. So what's happening in Pasadena should be happening in Friendswood if this were to be employed, and it should be at the direction of a treating clinician.
All right. That's one of the things I like about Chris, you being part of the team, is we have at one time today, I had one athlete in there. Sometimes I have 20 athletes in there. So if I'm in there trying to assess this kid and do all this, you can give him one-on-one attention because they schedule that appointment. They come in, and I'm really thankful that you guys have that as part of the team. And so I personally would prefer that in early stages of rehab that they come see you guys, they get the individual treatment, And then honestly, you're a lot more trained in all of that. If it's as far as the sport, getting them that kind of thing, that's probably where I'm better.
Yeah.
But you guys are definitely better in dealing with this. And so, I'm thankful there. And I'm going to continue to recommend they go, hey, look, first stages, go see, an expert, go see somebody that does this every day rather than me. So another question was, what about the heart rate sensors on the machines? Are those
are typically not as valid and accurate as the ones that you wear. There's usually some inaccuracy with those. So we typically would prefer that you use, again, we use the chest strap. It's probably the most accurate, but chest strap or one that you're wearing on your body is going to be more accurate than something on the machine itself.
Okay, so if nothing else, then that's better than nothing.
It's better than nothing, yeah. But ideally, you would have a monitor. That's going to be more accurate.
And then as part of the training, is there any sort of information that you give? Because you said everybody needs to be standard. Is there a packet that you give out, or that the original research they said, here's this packet to give out to the concussion doctor, and then the physical therapist, and then the athletic trainer? Is there any sort of information like that?
Right. So our program's been in contact with Dr. Letty and his colleagues, and that's how we really learn to do these things and also put our protocol together. So they were very great in sharing their protocol and information, and we developed a log. And so what we do is we educate the athlete on the process. We also educate the parent, because in some cases, of course, this individual may not even be an athlete. Maybe they're not, or don't have access to a great training room or athletic trainer, and so they're doing some things on their own at home. So we give them this log, careful progression, and then we have usually verbal communication as well as written communication with a school-based athletic trainer to inform them about what they would do, because we're all a team. And so the athletic trainer can then come back to us and say, I have some concerns. When he did this certain level, he did have an awful time sleeping that evening, or he had an awful time in class, so everyone's kind of in discussions. And so the athletic trainers have really appreciated us giving them guidance on how to carry it out in the training room.
That's actually one of the things, just hearing you say that about having symptoms later on that night, that's one of the things we have to check for, because sometimes you can have a latent onset of headache, and it may not happen while you're in your session, but you have, maybe that night they haven't done anything to provoke a headache, but they've got this splitting headache, and it's just killer all night, and maybe it goes away in the morning. That's something we're always trying to tease out when they come back in. And that's why, like you're saying, we like to see them at least every week, once a week, if not a little bit more when we start this, so that we can make sure that we're not having any of those symptoms. And that if we are, we're kind of scaling back the exercise to accommodate that.
All right. So is that paperwork? Is that somewhere where people can get to it, or, you send out as an example, like the guidelines, the instructions? Because, like I said, I got people in Tennessee all over the place that are listening to your talk right here.
Well, certainly we can provide you with some citations for the articles that we've reviewed and utilized in our preparation for our training. And then also, like I said, we were fortunate enough to be able to have communication with the group, University of Buffalo, that's really spearheading this effort. So I think you can always obtain those things in that fashion. And, of course, I think every program sort of tweaks it and modifies it based on their own certain circumstances. And I've always been mindful of our law and mindful of, for me, it's, I may be more or less aggressive than the next clinician. But for me, I usually start people after a week or two of doing the rest. And if I feel like there's not been any detriment to them resting, there's not been any progression at all, or they're really antsy. And then there's a number of characteristics, and it's hard to write all those down on paper, because it's more of an art than it is like, strict guidelines. But I might be even more aggressive with somebody who has ADD because they have a really awful time being sedentary, or someone with big psych issues who, their exercise has always been their outlet. So I might be more aggressive with doing this with them, because it's more of a good mental health type of booster. So, really, again, look at the person individually and determine if it's appropriate for them or not. And some people have so much on their plate, to throw an exercise protocol at them at that point would just be super overwhelming. And we have to take that into consideration as well.
Okay. I was just looking for, like I said, a way for them to incorporate this. And usually if you have paperwork, some sort of framework, and say, look, this is what they're doing here, this is what I would like to incorporate. And so again,
I think the best descriptions are really in their articles, and there's been multiple articles. And that's really where I would direct people. Because, if we tweaked anything, it's certainly ours, and, it's,
all right. So
may not be acceptable for every program.
So I'll try and get those from you before I post the episode. That way it'll be there in the show notes, or just as soon as I can get them, I'll post them up there.
Sure.
So, And that way, again, they'll have a framework coming from Dr. Letty there and everything they're doing. All right. So Chris, you're working the vestibular part, right?
Yes, sir.
So my kid here, he was in the Memorial Hermann system originally, and then his insurance wouldn't allow him to stay in the Memorial Hermann system. He was referred to vestibular therapy, but the insurance, I don't know, took months to approve it, and then they had to go meet with the physical therapist there, and then get approved for a second
More
visit.
treatment, yeah.
But like not even a treatment, just to like I had to do an interview or whatever it is there. So it's really hard for us to see, I guess, a benefit, because with that one kid, the one kid we've sent for vestibular therapy, there's not been any benefit because he's still sitting out doing nothing. And that was, I think, the week 3. So tell me, where is the big benefit in having vestibular therapy as part of the concussion program?
Well, the big benefit comes from the initial, I mean, you would be hopeful that this one patient would get into the clinician as soon as possible. Unfortunately, that's really an insurance issue holding him back. I'd love to see, so any of these people, the folks that Dr. Utt sees, I like to see them, and usually she's referring if they have this vestibular cluster of symptoms of dizziness and balance issues and kind of visual issues. We're trying to refer usually like 2 to 3 weeks, 2 to 4 weeks, somewhere in there, So the sooner you get to these symptoms, the better off they're going to be, because really they're pretty easy to resolve if you do the right training. So unfortunately for this kid you're talking about, the system, broke down in terms of the insurance side.
Yeah.
And unfortunately in the clinic, we can't help that because probably the clinician had no idea, or if they did, they're trying to help along, but authorization's authorization, and that's kind of the way the system's built right now. But I think part of that and what we've done with our system in our concussion program is we've tried to really educate the athletic trainers as much as possible in terms of what are the vestibular exercises that we do. And I mean, the VOR exercise, the basic exercise I give most people, is one that I would feel comfortable with a lot of trainers in our system giving, especially if, we've trained them sufficiently. And if, especially if I've at least given the groundwork to the patient, so if I've seen that patient for one session and they just need kind of that, accountability and kind of re-verification of, well, this is the speed you need to be going at, and this is how you need to be doing it. I think I would feel comfortable with several of our athletic trainers doing that. Obviously, we want to make sure the trainers are, proficient in that as well. But if it's a situation like this, that would be hopefully where the trainer could take over because the insurance wasn't covering the therapy side of it.
And I think those are really tough circumstances because sometimes, obviously we all have a common interest in getting the athlete progressed and to get better. But what I fear in some of these circumstances is whenever there is an inability to get the proper treatment because of an insurance barrier, then people start to take on some skills and do some things to help the person out of empathy. And then they actually end up harming the athlete because they are operating outside their scope of training. So I think it's important that, those are awful circumstances. And we usually try to make, arrangements so that they see someone at least initially and have the groundwork laid like Chris indicated. But I would just encourage people, please don't take on something that, works. But, I'm not going to start taping ankles anytime soon, or reading things that I shouldn't be reading in terms of imaging studies. So I think it's just important to let's keep finding a way to get them addressed without, operating unethically outside your scope of practice.
Mm-hmm.
All right. So you talked about what does VOR stand for? You said
VOR, yeah. So VOR stands for vestibular ocular reflex. So it's a reflex between the inner ear and the eyes that helps you keep focused when you're moving your head. So if I'm trying to look at you and I move my head side to side, there's a reflex going from my inner ear to my eyes to say, stay focused. That system is commonly impaired with vestibular issues after concussion. I mean, most vestibular issues, that's one of the cornerstone, training principles that we use. And honestly, when you do that one, in and of itself, it helps resolve a lot of the other issues. But, depending on how severe some of the symptoms are, we might have to incorporate balance training and some convergence training and different things, some visual motor training. But yeah, so that's one of the key elements of vestibular rehab.
Okay. So having just said, don't work outside of your practice, is that okay for you to share what that is with all of us?
Absolutely. Yeah, absolutely.
What is that?
With the VOR, what the training is?
Yeah, what the exercise is.
Yeah, so the exercise, what it consists of is I'm teaching, usually in sitting first, because most folks are very symptomatic and they'll get dizzy if they're standing, but usually they're sitting down and I have an X on the wall about an arm's length in front, and they're focusing on the X with their eyes. Okay, it's a fairly small X, about 12-point font. Okay, and what I'm doing is I'm finding on the metronome what speed they can do the, do the head movement and keep that X focus. So I'm moving my head side to side, looking at the X, kind of in a nodding, usually nodding no. Up and down's oftentimes much easier. So we start with nodding no. Okay, so nodding side to side, and I'm keeping my eyes focused. Okay, and the goal, ultimately the goal, this system works from 120 beats per minute to 240 beats per minute. And you want me to play that for you, how fast that is on my phone?
240 be pretty
240
fast.
beats per minute.
Beats per second, right?
It's pretty stinking fast. Let's see here.
All right, so how are you, do you just have to listen to when they say it's focused? Do they say, okay, I can't see it
I
anymore?
listen, well, and that's where the training comes in. I can see it. As I watch them, I'm usually watching. So if Summer's doing the exercise and she's facing the X, I'm always facing her. I'm never just watching the X because that gives me no input, right? I'm looking at the patient. I'm saying, oh, your eyes are slipping, or, I'm seeing something going on with what's going, with the movement they're doing. Sometimes the movement's real poor and you can see, okay, they're really dizzy. You can see it in the way they're moving. So,
and Chris can obviously pick up on a lot more things and sensitive to it than I am. So like we'll even co-see people together frequently, and he'll see things that I'm just not trained to see. So I think that's another advantage to, again, relying on somebody that has this expertise.
Yeah.
All right, so let's do the 240.
240. So this is the max. This is if we have a high school athlete, college athlete, this is where we want to get them to, because this is the max of the system, but that's how fast the beat is. So it's pretty quick. And the idea, so what we do is we have them do that for 2 minutes at a time while focusing on the X. Okay, and so the progression from sitting
2 minutes at a time.
2 minutes at a time.
So consistent 2 minutes of shaking your head.
Consistent 2 minutes of shaking your head. Yeah.
And you've successfully completed 240 beats per minute, 2 minutes.
Absolutely, yeah.
Staying focused.
I won't say that I'm not dizzy afterwards.
Okay,
but.
that's what I'm wondering. That's what I'm wondering. Like if I'm
No, and we all, and again, but I'm not quite the athlete I used to be. So if I was in high school, this would probably be easy for me, right? And being an active, I played soccer, so being a soccer player in high school, that should be easy, right? You might have a smidge of dizziness right at the end, but it's going to go away just like that, and it's not going to be bad. With our concussion folks, we'll put them at 120 beats per minute. And they do 30 seconds and they're about to fall out of the chair. So it's a huge progression, and you start really slow. Sometimes I'm starting even at 80 beats per minute, with complete, hand hold on the chair so they don't fall over. So it's a very, it's a spectrum of where we get folks. And again, depending on where they are on that kind of spectrum is where we start, and kind of we will progress in certain ways from sitting to standing to walking. Sometimes I'll have them hold a target and do this while they're looking at the target in their hand while they're weaving cones. So imagine doing 240 beats per minute, moving your head, holding the target and weaving cones back and forth. It gets challenging. But again, if you want to be a finely tuned high-level athlete, this is the kind of stuff you want to do for vestibular rehab.
It still seems like if I shook my head for 2 minutes, it just still seems amazing. And then to amplify it by standing, by walking, by following a pattern while you're doing that. So again, I don't, like you said, Doctor, I don't think that this is something that most athletic trainers in an athletic training room are prepared to deal with.
No, but I think that it'd be important for us to identify what you would be looking for.
Right.
So, because sometimes, you sent athletes to physicians, maybe they aren't trained in concussion management or sensitive to some of these issues. And so some of the things that I educate people to look for are just a pretty common set of cluster of symptoms that when they say yes to a number of these things, you kind of start to get the ball rolling with what do you want to do next with your assessment, like you would do anything with a knee or whatnot, with any other type of injury. So the things that I look for are symptoms when they say, I go to look up and I feel dizzy, or I turn my head quickly, someone called my name and I felt dizzy. I watched movement on television. I can't watch any sporting events because the fast-paced movement of whatever's going on the screen is bothersome. I'm very light sensitive. I go to Target and people walking beside me, or I'm in the hall at school and they're changing classes. It's just overwhelming. It makes me feel really panicky. we, balance, they're very unsteady at times. There's a number of things, riding the car, any kind of motion that they feel, rolling over in bed. I mean, there's a number of things that, might be also good for us to hand out as far as like a checklist kind of thing about, what can we look for, because headaches can also be because of the vestibular dysfunction as well. So once that's treated, those headaches that are debilitating people can also leave.
All right. So if we were to kind of go back through, see, Tian's got a question here. Go ahead.
What does a normal appointment with the vestibular PT look like?
Yeah. So, let's say we have the patient that's gone through the aerobic progression in that protocol. Then usually my initial thing, because I want to make sure they're not going to have any, symptoms that come on later in the session, my first thing is usually to do about 15 to 20 minutes of aerobic progression. So on the stationary bike or the treadmill. Once we finish with that, I'm making sure they don't have any cervical issues, whether it's range of motion or, any deficits or dysfunction in the neck. And if they do, then I'm doing some manual therapy and stretching and techniques to work on that, right? Once that's clear, then I take them to that VOR exercise that we were talking about. If you start the VOR and they have neck issues, all that movement with your neck just makes it worse. So you have to make sure you kind of fix the neck and get posture and neck components working first, and then you work on the VOR. So, we work on posture and cervical strengthening, and then we incorporate the VOR. And depending on where they are, I might just put them in the room and progress their VOR from last session where it was maybe at 120 and now they're doing 125 or 130. And I'm just making sure they can do that. And then I'm giving them the right speed to work on at home. Okay. Depending on, maybe they're a little more progressed, then I'm going to take them into more of the difficult things that we were talking about. So you're weaving the cones while doing the exercises, maybe standing on compliant surfaces on the Bosu or foam, foam pad, and doing so. We'll do it on foam pads as well, which is pretty difficult. Okay. The other part of the posture that we hadn't talked about is the balance components and working on vestibular balance. And so the vestibular system works on gaze stability, which is what the VOR trains. There's another big part of the vestibular system that works on postural control and balance in and of itself. So you isolate that vestibular system when you close your eyes and you stand on something squishy, right? So if you do that, so stand on the Bosu and then you close your eyes, most of us will fall over because it's kind of hard to do. But that's because you're utilizing that vestibular system, and it's really the least utilized system, especially as we get older. But overall, we'll start training that as well. So we work on gaze stability with the VOR, and then balance exercises to work on postural control.
All right, Juanita, what was that? Oh, it's way up there. Oh, you're going to ask a question, and then I hate when I do this. I'm listening to see what you're saying rather than thinking about the question. It was about, how long do you wait? Because a lot of athletes don't actually need the vestibular therapy. So what are some of the things that how do we know if they need that? And I mean, obviously that's going to be your call, but how do you know, or how long do you wait, or what tells you to send them to Chris?
I'm glad you asked that question, because I think we're all struggling with the answer to that. I mean, it's not been investigated or verified by any research necessarily. Anecdotally, in the team that I work with, the physician team, we've sort of got together and determined what would be best practices for our group and what would we feel comfortable with, including Chris and some other experts in on that. And so like if Chris and I were to see someone, which we have the luxury of seeing people, sometimes much like you do, maybe the day after or so forth. And I would say many of those systems are disrupted and people have a lot of balance impairment, a lot of visual problems and ocular motor challenges and so forth. But more often than not, I mean, most concussions resolve within 1 or 2 weeks, at least statistically. And so those symptoms by the follow-up visit in 1 week are generally resolved. But there are those people that, by the next week, if they still haven't showed any improvement on our physical exam in those different domains, then we are going to start suggesting that they have an evaluation and carry it out from there. But most remit. And so, again, we don't want to over-interpret or over-send, but, we might be more aggressive too with somebody who's had multiple concussions because we know their recovery is going to be longer. So why not go ahead and start being more assertive with the treatment?
All right, Chris, what are your thoughts there on the same thing?
Yeah, same thing. I mean, I kind of like I mentioned earlier, a lot of times we're getting folks after a couple weeks, 2 to 4 weeks, but there's really, I don't think any point to push too hard in those first 2 weeks because like Dr. Ott said, most people are going to resolve. So usually by 2 weeks to 3 weeks, we're having an idea of who's going to have some residual symptoms. And at that point, we'll start doing therapy. And again, the sooner we get this therapy started, the sooner it's going to resolve. So even if they're going to resolve anyways, this will only help it happen faster in terms of the vestibular treatments.
All right, so there's a question about C3 logics and utilizing VOR. You guys have any thoughts on that?
Yeah, so the C3 logic is an abbreviated battery, which the unique part of it compared to most, I guess, assessment tools in concussion is that it has a balance component. It has the ocular motor component. It's assessing a brief assessment of symptoms, brief assessment also of cognition. So it does have that component. We don't necessarily use C3 logic in our program, but we do all the variations of it. And, at this point, I think C3 logic still is undergoing quite a bit in terms of reliability and validity checks, but it does certainly have that component.
All right, so one of the things that you just mentioned was that you guys kind of get to see them early on, but typically as an athletic trainer, we're some of the very first to see the concussion. Maybe it's right there in front of us. Mm-hmm. So is there anything different as far as test-wise or anything that really indicates a concussion to you, or maybe that something's really not right? Chris, as far as balance, what are your favorite?
Yeah, so balance in the clinic, what we're usually testing is the BESS, balance error scoring system, right? Oftentimes with concussion, though, just the simple balance tests of, tandem and single leg will be impaired either with eyes open, but oftentimes with eyes closed. I mean, usually with eyes closed, but if it's a bad concussion, they're not going to be able to stand there, sometimes with their feet together. So the simple balance tests on the sideline, I mean, if they're going to be tested soon after anyways, I don't know that if it's clear it's a concussion on the sideline, I don't know that you'd want to really go through all of those because you're not going to put them back in anyway. So I would wait and give them rest. But, I use the BESS and I use those common, the single leg stance, tandem stance. I don't do as much of, the FGA or DGI, kind of more the standard outcomes, but I really enjoy those easier balance tests. And they tell me a lot, especially on the BESS when if we have the higher level athletes that can kind of, make it through some of the easier balance tests, the BESS really kind of teases out that they have a lot of issues.
Dr. App?
Yeah, and one of the things that's often asked too, is there anything in the immediate presentation when you all do see them on the sideline that could be predictive in, okay, this person's going to have a vestibular dysfunction and require therapy and this person isn't? I'm not aware of anything conclusive or any study that really has identified several characteristics. I think they're more apt to, we can identify them as the person's been seen more post-acutely, but that would be a very good, awesome, study too to look at is what are those characteristics immediately, and maybe that's out there and I'm not aware of it, but
there's some of the research shows that dizziness on field, so at the time of the concussion, is probably the highest indicator if they have dizziness as opposed to any of the other symptoms, headache, nausea, any of that stuff. Dizziness is probably the highest indicator of prolonged symptoms after having a concussion. So that's something that if you see someone that is concussed and they have dizziness, you're going to want to keep an eye on them because they might likely have prolonged symptoms.
Well, and then, same thing with headache though. So there's a lot of symptoms that, as far as like prolonged that might be evident at first, but as far as purely can we ascertain, is this person migraine or psychiatric or, that's really tough to know.
All right. So then at one point when I came up to the Saturday clinic, Dr. Wright, you had talked about how dehydration has a lot of the same characteristics as concussion. And so if we're looking at a kid that's, been, say, a soccer kid, been, playing for 39 minutes and they're tired because they're breathing hard and maybe they're a little dehydrated. Is dizziness going to be one of those symptoms that they may have, even if they're not concussed?
Yeah, I think that when there has been research to look at that specifically, to tease apart that aspect, they've found that, certainly a lot of the symptoms are overlapping, but usually there should not be a balance disturbance in individuals that have dehydration. They will complain of lightheadedness and dizziness like someone with a concussion. But, again, after you get them treated, you're suspecting your etiology is dehydration. You're getting them in a, nice environment, a cooler environment, hydrated. and their symptoms are persisting into the next day, I mean, you have to sort of rule out that dehydration may have been on board, but there's something greater going on now. And I think that's where there's a good opportunity to follow up with some neurocognitive testing too the following day to help with your confirmation about what may be going on.
Anything?
About the same. Yeah, they can. I think they can absolutely present very similarly on the field, but either way, you're going to probably be giving them water and giving them rest, and usually hydration or dehydration is going to respond to hydration. So if you're getting them, give them some Gatorade and some water, they're probably going to feel better if they're dehydrated. Maybe not right away, but definitely it shouldn't last overnight and things like that. But if it's concussion symptoms, they're going to have residual symptoms a lot of times.
Okay. Just to kind of go back over, we talked about the sub-symptomatic post-concussion workouts. And can you tell me the doctor's name? I keep saying Leggett, but I think that's the
Dr. Leddy.
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 Leddy. So Dr. Leddy, and you said there's Ohio?
Buffalo.
We're going to test Jeremy's
Buffalo?
Cognition later.
Is Buffalo in Ohio?
New York.
University of Buffalo.
I'm from Houston. All right, so
Somewhere in the Northeast.
yeah, somewhere up there. All right, so Dr. Leddy Leddy from Buffalo, they've been doing the research on the subsymptomatic post-concussion. They prefer the chest heart rate monitors. They want to keep did you say 60 to 70% of the indicators?
That depends on the patient. So,
Okay.
and that's where our clinical expertise is coming into play there as well. So if it's somebody that's slightly more symptomatic and maybe they're setting into symptoms at a lower heart rate threshold, you might start them at a lower percentage just because they're super symptomatic, right? If it's somebody that's making it pretty high up there, 150 to 180 and even higher, sometimes I'm going to start them maybe at 65 to 70% and then possibly even progress more rapidly. But again, it just depends on how the patient's responding.
And what did you say too, that if you have somebody coming to you, that we've seen some of these kiddos and adults even who haven't done any physical activity for like half a year,
Yeah.
I mean, you're going to be much, less assertive than somebody who's been inactive for maybe 3 weeks. So I think that would also play into your consideration.
Yeah, exactly. And you get a good idea of that once you put them on the treadmill. If they're huffing and puffing when you're at like 30 seconds, then you're okay, well, we're going to have some issues, but
That might be me now, but
yeah, exactly. Usually you have an idea once you put them on there, but it's hard to put a definite thing on that because it definitely varies per person.
All right, and then as Dr. Ott said earlier on, that you want to not work outside of your practice, not do something you're not trained to. And just because a kid might not be able to see a vestibular therapist, don't try and take on that role, because that's not what I do. And so some of the ways that you test them is by putting them on a treadmill at, you said 3.5 miles per hour.
Yeah, I mean, so what we
Standard.
use is the Balk treadmill protocol. So, I mean, I'm sure lots of trainers are very familiar with that. We do it, and it's just a graded exercise test. So, off the top of my head, I don't remember exactly. I think that one starts at it's different for males and females, 3.3 or 3.4 miles per hour, and then you're pretty much just increasing. I mean, essentially, the protocol is somewhat irrelevant as long as it's a submaximal walking treadmill protocol. That's really what you need, and you're just starting to increase up the heart rate at a slow rate. You're not going to jump them up right away to 5.0, but if you slowly increase them in terms of the incline, it starts to bump that heart rate up, and as it goes up, then you can kind of see when they have symptoms. So we use the Balk treadmill protocol. You can Google it comes up, but I can't just recall that off the top of my head.
All right. And so then, like you said earlier, the indication is headache. So they're walking, and as soon as they get to, you're like, oh, I have a headache, or you're noticing they're kind of shaking their head, or something seems different. That's the point where you say, okay, this is your heart rate, because you got the heart rate strap on them, that we want to base our 50 to 60 to 70% off of, that you said earlier, which is highly individualized again. And then again, this is something that could be done inside of an athletic training room with proper training and individualized attention. It
could be. But then just like Dr. Ott was saying, if I think we're happy if people are trained appropriately to have them do this. And sure, it's going to be more convenient for patients. But the problem is this can be super dangerous for the recovery of the athlete if they do it improperly, right? If you push too far into headache, it could set them back weeks. I had a guy that we cleared for this. And even as we were kind of managing his care, he went home and didn't follow the heart rate protocol we gave him. And he pushed a little bit too much and went jogging that day. And it set him back 2 or 3 weeks. So we had to start all the way back from the beginning. So even in a very, strict and a one-on-one basis where you don't have, 20 other kids trying to get attention from the trainer, it was difficult to kind of manage this one guy. So it can be difficult. But yeah, I think if they're appropriately trained, a graded exercise test is something that a trainer can do for sure.
But then Dr. Ott also mentioned that this would be something that'd be very touchy here in Texas because of our law. So at this point, you are the person that she's referring the athlete to for rehab.
Yes.
And so part of that concussion protocol states that they're supposed to complete that. They're supposed to have that form filled out and saying they're clear to begin the exercises, but they're not actually clear to begin exercises with us until they've completed the sub-maximal heart rate workouts with you. So then and there's another tricky situation. So for us here, the easiest thing to do is to send them to doctor, check them out, send them to Dr. Ott, and then if need be, she would refer them to you for this process and then return them to us for the return to play protocol.
Yeah. So everyone that sees Chris, of course, has seen a physician and myself. So to be, pertinent or compliant with the law in that respect. So, all of the therapy is physician ordered. And so we're just all working together as an interdisciplinary team. And both Chris and I would be, talking back with someone like yourself about how to progress this. But again, we always stress because, the coach will walk in the training room and say, oh, so-and-so is good to go. We can start having them on the field. And no, again, this is rehabilitation. This is not starting the return to play protocol. And how I think it's beneficial is, within the law, it does say returning back to things that are scientifically validated. And I think that we have that evidence here in this particular opportunity, but just like anything, they're not returning back to the floor after an ACL or the field. They're doing the rehabilitation, whether it be in the athletic training room or in the gym. So, or in the PT clinic.
Yeah, in the clinic. And that's kind of how we work. I've had several kids recently that have been going through this aerobic progression. And what I've done is I still see them once a week and kind of update that protocol and make sure things are going well. And if they're having issues, I'm really taking the time to tease out, are you having headaches? And I'm just, really being nitpicky about it and kind of takes them off. But, you ask them the same question 10 times just to make sure they're telling the truth because they want to go back to play too. Yeah. Yeah. So I'm keeping up with them on a weekly basis, but then that's one time a week. The other, 4 or 5 times a week, they're actually following up with the trainer, and Dr. Ott and myself and the physician are all in this email chain, and we're coordinating with the trainers as well, so that we're all on the same page, and we all know, well, if, they're expected to be at this heart rate, and if they have any symptoms, we jump back to this heart rate. So, it's still very specific, but it all works well. And I think is legal under the law as long as there's that good communication. We're all kind of working as a good team.
I think you ask yourself, do I feel comfortable with this? And then I always think a good rule of thumb or practice is if I were asked or subpoenaed or I'm on a witness stand, can I defend that I have the training and or can I answer the questions that are going to be posed to me about the safety of the athlete? So I think when we all get a little bit anxious about, well, what's the newest thing that we can do to get the athlete back, or the best tool, or it's definitely the wild, wild west out there, like my colleagues have been indicating about the latest and greatest concussion tool. Can you really defend it when it comes down to the safety and well-being of our athlete?
Yeah, that's why I wanted to reiterate that don't go beyond your practice. We don't have the time to individually, usually inside the athletic training room, to individually focus all that attention. And also that prescription for rehab is usually not with the athletic trainer, at least in this point. And so again, stay within your practice, stay within what's legal, be able to defend it. All right. So Rachel's asking, what's a typical, there we go. What's a typical time frame you see an athlete ready to go into a return to play protocol following the submaximal heart rate? Is there anything, because like we've said several times, it's individualized, but
Very individualized. You know, the problem with that is we're starting this aerobic protocol when patients oftentimes still have symptoms, and you don't start the return to play unless they're completely symptom free and oftentimes fully reintegrated into school and are caught up on schoolwork, right? So if you say, oh, well, from the PT side of things, they're doing great, aerobic protocol is progressing well, let's just send them into phase 2 of return to play. But that can't really work, because you have to look at the whole other side. You have to look at what Dr. Ott's doing with the neuropsych, and you have to look at cognitive function in school, and are they still on these modified schedules and things like that. So it's hard, because from a physical point of view, I see like, yeah, they're almost ready to go physically, but you have to step back and say, well, that's not the most important part here. We need to get them back into school and get them back into return to classroom and full-time, things like that. So it's hard. It's hard for me, because you can see they're like, man, I'm doing great. I'm progressing well with this aerobic stuff. And then I've got to be like, well, let's hit the brakes here. Go talk to Dr. Ott and, whichever physician you're coming from, and let's have this conversation of what we need to do to get everything else back into, quote unquote, your normal routine. And then once you have no symptoms and you can do that, then oftentimes that's when I think as a team, we're saying, okay, maybe you can go back and we'll integrate you into usually phase 2 of the protocol. But
there's been plenty of examples, I think, of people coming like 9 months later with, chronic post-concussion syndrome and symptoms that have, really had no guidance with respect to rehabilitation. And so those people that we do send to your program, or we send and we start working with holistically, again, anecdotally, I see some pretty good progress pretty quickly. They just hadn't had any exposure to the right treatment for some time. So.
All right. So you said you guys, you see them, and then an orthopedic doctor, usually Dr. Crumby or Meeks or something like that here with this. So if we have a kid that, she hits her head on the floor, her neck is really hurting, but she doesn't have any other symptoms, but her neck is hurt, and it kind of makes like her eyes hurt. Is that like, oh, hey, I need to send her, or like, well, the next day her neck hurt a lot, and she still had a little bit of headache, but balance and memory, everything else on the scat was great. So at this point, I'm like, well, from what I've seen, like the neck muscles could be just causing the headache, right? Was that a bad idea? I mean, it's done, right? And I didn't mention any names, so.
So that's really tricky, because I mean, if you indicated they hit their head, then you have that particular thing to consider. And if there's any suspicion, you obviously withdrew them from whatever activity they were doing. I think we all have situations where we've been able to say, okay, I'm glad I worked it up as a concussion, but it really wasn't. And it was a cervical issue causing the dizziness or whatnot. So I think, again, I should see a physician as well as yourself and get that ruled out, and then, proceed with the best course of action based on what's deemed to be the etiology.
If you have doubts, I mean, you're going to know probably within the next week or two as they get back into schoolwork. If it's a concussion and they have issues, likely they might not mention it. So it might be good as a trainer, and you see that they have that accident, then keep a close eye on them, keep questioning them about schoolwork and things like that. Are they having issues? But as a PT, from that standpoint, that patient would be perfect for PT to do cervical rehab, and even you can have dizziness and imbalance from just cervical issues. So if you have any cervical dysfunction, whether it's from concussion or not, you can definitely have some dizziness, headache issues, imbalance, so yeah, in a way that could present as a concussion, but maybe just be cervically related. So yeah, still appropriate for PT, but it'd be hard to say concussion or not in the moment.
Yeah. So that's one of the things is, we're everybody is scared of concussions now. And so, obviously if we suspect anything, then we need to put them through the test. And like I said, the next day she had a headache in her neck, but then the day after that she was completely fine. But I'm just wondering, did I miss something? Because I'm trying to take everything that I'm learning, which is, where they evaluate the whole athlete, the neck, the head, everything, and not just, all right, well, the athlete hit somebody and then fell down, because I didn't actually see it. She's like, well, she bumped me and I hit the floor. Well, I don't know if she snapped her neck back or what. And she didn't know either. Yeah. But so it's a tricky situation.
It is. A lot of times those headaches that come from the neck, it's coming from that suboccipital region, and it will refer from the back around kind of the sides to the front. And sometimes they'll feel it right behind the eyes. So oftentimes, if you give them maybe some cervical stretching and maybe throw some heat, if you have heat in your training room, right? Put some heat on there. Oftentimes that will take care of a headache and decrease it. If that decreases it and there's a positive response, then you can say, well, maybe that's a cervical or a cervicogenic headache, right? You know, and again, you still obviously want to clear the neck, make sure everything's, you know, intact there, alar and transverse ligaments, and then, you know, check for vertebral and basilar insufficiency. But as long as you're cleared and then you're kind of checking range, I would stretch and kind of do some heat and see if that helps it, then likely it's just a cervical issue. And especially if you're kind of monitoring them and they don't have any further school or cognitive issues. But that's maybe a good way to tell, you know, so the cervical headaches oftentimes wrap around from the back.
All right. So again, let me, I guess, qualify, do what you're trained to do what you're comfortable doing. Right. So if you're not comfortable doing that, you'd much rather send them to a physician than send them. Right. But I was doing what I've been, you know, what I was taught, what I had learned, and I was trying to do what I thought was best. So again, don't take this as, well, Chris said, just put some heat on it.
Please don't do that.
But that's a good clinician. I think the clinicians that always ask themselves after the fact what they could have done differently, what they did right, what they did wrong. I mean, that's the doctor you want. You know, that's the athletic trainer you want. That's the PT you want. So, you know, we always ask each other, I mean, you know, or ourselves, or we should be. If you're not, then I advise you to do so. Really always ask what you could do differently or what could have been better.
All right. So there's a question from Carlos. Protocols for loss of consciousness under 10 seconds. Says, when you know of a head injury and if you do not know if it's related to head trauma. A head injury, not loss of consciousness.
Well, I mean, we know that loss of consciousness is certainly rare many times in concussions. They happen, but they're not as prevalent as one might think they are. When people, you know, when I ask about those things, the mental status markers, and people say, oh, I was unconscious for, 3 hours, it's super unlikely. And if that were the case, they'd be in a trauma center somewhere with lots of things going on around them. So it's important to distinguish what was I don't remember for 3 hours and what was amnesia versus was I unconscious and getting verifiable information.
So basically anytime they're unconscious, loss of consciousness.
Yeah. If there's head trauma and they've lost consciousness, then it's suspected concussion anyways, right? So.
Yeah. Yep. All right. So I was kind of like, I don't know if I was wrapping it up, but I was summarizing just to make sure that I was clear. We were at the phase where you put them on the treadmill and then they're walking, the headache, the peak, and then that's where you know that they got to work. And then we talked about how they have to complete those workouts until they get back till they're clear with you, which means they can begin the RTP with us, right? So those kids, you said you might see them once a week, Chris. Hope preferably more, but those kids, I know that we had a kid here when they first started doing that. He had the heart rate monitor, and he was supposed to check in with us, and then we had to send the paperwork back over to Dr. Ott's office, like his heart rate log and that kind of stuff. What does that look like now once you've set the kid up on that workout? Do they have that log that they are supposed to check in with us and we send that back to you? Is there some sort of digital form you guys are doing right now, or? It's
a paper format right now. Yeah. So it's just a paper log. And a lot of the kids are, one of the girls I'm thinking of, I know she's just given hers to her trainer at school, and her trainers document it for her during the week. And then she's documenting at home as well. So, and then we're in email communication usually with the trainer to get feedback on that.
All right. So we don't have to submit it to you regularly.
It's good to get kind of like a weekly update, but it's not like a formal, here at Friday at 12 o'clock is your, it's literally, again, it's just kind of keeping that communication up between the trainer, Dr. Ott, myself, and the physician. So, and a lot of times the physician is in on these emails too, because we're clearing through the physician to get that approval to do the training in the clinic and also through the school. So.
All right, let me see. All right, so then once that you've given them to us, would there be any reason for them to go back to you once we've started the RTP? So maybe if they can't get out of phase one after a week, then we need to send them back or something like that, or?
Yeah, I mean, usually they're going to be, so if they're going through our aerobic progression, they'll be in phase 2 pretty much. I mean, complete rest has already happened, so they'll be in phase 2. And if for whatever reason they're not progressing appropriately, I think that's where you want to make sure you talk with the whole team, so get with the physician, get with Dr. Ott, get with myself and say, hey, here's what's going on. What do y'all think? And then we would have communication as a team and decide probably what's best. Sometimes it's appropriate, so maybe there's, as they get more into the sessions with y'all or into the return to play stuff, maybe you see there's actually some vestibular things that we may have missed. If we focused on the aerobic training, maybe we missed some vestibular stuff. Usually I try and screen them, but I'm not perfect. So maybe I missed some things and they're like, hey, this looks like a vestibular issue. Let's send them back. Sure, that'd be appropriate. But I think really in a situation like that, you're probably getting with the whole team and seeing what's the best plan of action.
All right. Any additional thoughts there?
I think that was well said.
Yes.
All right. You're hired. You get to keep your job. Okay. So I think that pretty much sums up the sub-maximal heart rate with the vestibular. One thing, just in balance in general, if I want to help these athletes improve their balance, because we talk about ankle sprains are, partly because of proprioception and that kind of thing, so if they strengthen their core, they strengthen their balance. So what are some of the things that I can do to help my athletes improve their balance to hopefully prevent injury?
Well, think of balance as kind of a 3-tiered approach, right? So you have 3 sensory systems that help you keep your balance. The first is, aside from the motor control, obviously you have to have strong muscles, right? So make sure the core muscles, the hip muscles, ankle and knee muscles are all strong. But aside from the motor component, you have 3 sensory components to keep your balance. Somatosensory, right? So how you feel the ground through the feet, including the light touch of the ground and different, bumps and grooves on the ground, but also that includes the proprioception through the joints and the muscles, right? So somatosensory, vestibular, which we've been talking about, right? So it's that vestibular component of gaze stability, using your eyes to focus, and also the postural control of, standing on a compliant surface with distracted or no vision, okay? And then vision itself is your other way to stabilize. So you can tease those out in a bunch of different ways. Obviously, vision is the most used, most easy. It's what we default to. Somatosensory is one of those that if you want to train that, you just, standing on the flat ground, closing your eyes, you're going to default to somatosensory automatically, right? Vestibular is kind of the least used. So if you want to really tease that out, if you have a soccer player, you're going to be doing maybe standing on the Bosu and doing, half volleys or volleys back to, as you throw the ball to them. And so they're standing on a compliant surface and then they're distracting the vision while looking at the soccer ball as they're trying to kick it. So it gives them some visual cues. You could just have them close their eyes, but if you're doing training in a training room, I would make everything as sports specific as possible, because that's going to be, the most applicable and you'll get the most carryover.
All right. So working all 3 components of the balance that you said, well, one, check and make sure the muscles are good and strong.
Yes, sir.
Right. And then varying up how you're doing that. So maybe one day you're doing, eyes closed, just single leg balance, that kind of thing, because you don't ever play sports with their eyes closed, right?
Yeah.
So then the next time it may be that they're just standing on an uneven surface with their eyes open, or you may just, like you said, kicking the soccer ball or, catching a basketball, those kind of things to distract their eyes. So just distracting their eyes and having them on an uneven surface, that trains the vestibular. It
helps focus more on the vestibular. Yeah. So you're integrating more of that vestibular input at that point.
Okay. All right. Now there's a question from Callie. Says, do you have a particular injury psychological readiness to return to sport scale that y'all like to use? Sorry. Dr. Ott?
Well, I'm a clinical psychologist by training, so I don't necessarily use a sports scale per se. I have a pretty detailed clinical interview that I do that's structured to tease apart any kind of contribution that might be happening with respect to secondary depression or anxiety or other things that might be inhibiting the process. But I do teach a sport injury class, psychological aspects of it at U of H in the Masters of Athletic Training program. So we certainly talk about instruments that athletic trainers can use if they feel like there are some issues going on with respect to that, but they're usually pretty brief, and I probably couldn't name all of them off the top of my head, but they do exist. Most of the time, though, I think just a careful conversation is probably the most accurate. You know your athlete the best, and what seems atypical or normal for them.
All right. So, Chris, a question for you. What might an athletic trainer do to kind of interview or to be sure that the PT is on the same page? So Rachel was asking what questions to ask how they're doing the submax protocol, because she had an athlete that they wanted to start it when they were still having light sensitivity, headaches, and those things being compounded with reading. So what are some good questions for an athletic trainer to communicate properly with the PT about the athlete?
I mean, I think the biggest, most obvious would just be, hey, do you think this patient's appropriate for return to play protocol? And then from there, I would say, well, yes or no, based on what I'm saying. But again, I would never probably say yes without saying, well, here's what she's doing or what this patient is doing in PT, but, let's talk to Dr. Ott and the other physician and see what their thoughts are too. Because again, it's not really my call. As much as sometimes I wish I could make that call, I'm happy to defer because I don't always see the big picture because I'm working on one aspect of it. The physician and Dr. Ott are usually looking at that bigger picture. So I'll defer to them a lot of times to say, well, they're going to make that call, but here's how they're doing in PT. So I would say just pose a general question. And I mean, be straightforward about it. I have no qualms about answering anything. So yeah, if you have a question, let me know. And for the PTs, ask more specifically the things we work on, ask about the vestibular issues. Are you noticing any symptoms in PT? This is what they're having in the training room, that kind of stuff. But, again, if they're having any symptoms at all, then they're probably not appropriate for return to play. So
any other thoughts there? No. And again, here it's part of a team, but Rachel is actually in California.
Okay.
And I know that there's an issue between like athletic trainers and physical therapists and like physical therapists working as athletic trainers. And I don't know all the details, and I don't really, it doesn't apply to me because I'm here in Texas. Yeah. But, it's kind of a different issue, whereas there is that PT might have been in that setting with the athlete dealing with all this. And so I don't know all the details of that, but so good. Just make sure you ask the question.
Open communication is probably always the best, but obviously certain situations make that more difficult.
And I think I went to the Sports Medicine of the Americas, and Dr. Andrews talked one year, and the one thing that I always come back to is make the athlete or make the patient believe that the last doctor or last clinician that they saw make them feel that last clinician did the best that they could to treat that athlete. So that you might see it differently. You might pick something up differently, but I did the best I could to take care of them. I might have missed something. Yeah. And then Dr. Ott's going to see her and she does something maybe opposite of you, but you did the best you could at that time.
I think it's scope of training too. I mean, in our law in Texas, physicians have to see an athlete and clear them, but there are plenty of physicians that have not had any concussion training, probably haven't went to a CME training in concussion in quite some time because it's not mandated. And so, again, they have to be comfortable when they need to know to refer. And when people aren't or individuals aren't recovering within, the time frame that might be acceptable or the norm, I mean, at that point, you got to ask, who else can help me take on this athlete so that they can get better more quickly and put your ego aside. So, when we can all do that and we all need to, get peer consultation.
All right. Yeah, again, I think you're saying just working together as professionals, encouraging or speaking well of other professionals, and don't say I'm better than you, or no, that other athletic trainer was stupid. They don't know what they're talking about. Well, this makes us all look dumb, right? Well, then, if that one didn't know, then how do I know you do? So I'm kind of bringing it to a close. Chris, if someone wants to get a hold of you, how are they going to do that?
My email would probably be the easiest. So it's christopher.shields@memorialhermann.org.
Christopher.shields@memorialhermann.org. Twitter, anything like that?
I don't have Twitter.
You don't have Twitter? Okay. Snapchat?
You asked that earlier. I don't tweet. Yeah.
Well, Dr. Ott was just telling me she just started on Twitter, and which is at OTT Summer, right?
Correct.
Summer. So that's her on Twitter. But how else can somebody get a hold of you?
Certainly the best way, I think, is to talk to Rihanna, my right-hand person, 713-704-9647. She's our program coordinator. And I have a super long, huge email that I probably just won't even try to attempt to say. But that's the best way, that phone number. And, many of you, have my cell phone number. So, call me, and we always, certainly are approachable and want to address questions. And I think we do have a lot of opportunities for training as a group. So I'd encourage you to reach out.
All right. So what did y'all talk about on Root Sports this morning?
Yeah. So that's fun. So we were involved in a segment today where we were talking about, again, progressive exercise for more complicated concussion recoveries. Also the recovery rate of female athletes. That's also something that I think doesn't get a lot of attention. And Chris and I were working with one of our triathletes who had some pretty significant post-concussive symptoms, and she certainly made a nice recovery back and doing really well.
All right. Is that about what you said, Chris?
Yep.
Just, yep.
Yep.
She's the boss. All right. So, Doctor, you said you were going to try and get the link to me about Dr. Leddy Letty from Buffalo, which is not in Ohio, which is in New York. and then that way people will have a framework to approach their concussion oversight team, whatever it is in their state, depending on their laws. And then that way, they'll have somewhere to start rather than just saying, I heard this one thing somewhere.
Yeah. By far, I would espouse that I am not the expert in sub-maximal threshold exertion testing. It's just something that I feel like has really benefited the people that we work with. So I turn to the people that are more of an expert. And Letty, of course, is to me one of the foremost experts on this. So we're just trying to carry out the things he's done with respect to this rehab.
Yeah, I think I've never had a concussion, but I think it's really good to allow athletes to move.
Yeah.
So, we were so far, again, this is my unexpert opinion. We're seeing, we're so far, complete rest, let them stay in a dark room for, 24 hours a day. And then wait, that's making them crazy. So now just allowing them to be natural, like you said earlier, less anxious about everything, well, then that decreases symptoms. So
yeah, when you isolate people and they, start to be on homebound and all these things, they start to acquire lots of psychological issues and particularly adjustment issues. And so then you're treating more of a psychological component than you are physical aspects.
That's why you're the psychologist there. So you're the professional. All right. I think any other final thoughts about submaximal heart rate, vestibular therapy? Chris, Dr. Ott?
I think we covered it all.
All right. So then coming up next Wednesday, I have episode number 200. It's going to be really cool. Lots of prizes. School Health has got some stuff coming for me. Bubba from Memorial Hermann has a whole bunch of goodies that I'm going to be giving away. Craig Lewin is going to have some essential oil stuff. Okay. So real quick, essential oils. Do you think any of that might, off the record on the air, not official statement, do you think any of that stuff might, like lavender might help because it's supposed to help sleep? You think that might help with concussion symptoms? Not to heal it. We're not going to say not to get over it better, but symptoms?
I think everybody's probably found something that works for them and not the other person. But as far as what really treats or manages concussion, rather is a better word, is, again, I think it's important to do things that are scientifically validated and, and spend less time trying to search for something that is not.
All right. So anyways, Craig's got some of that stuff, essential oils that may help with skin conditions or muscle problems, that kind of thing. That's really what it was. But since it just came up and you're here, hey,
you wanted to put me on the spot.
Yeah, might as well ask an expert. So sportshealth.com/SMB. That's where you can register each month using the February password is SPATS, SPATS, where I'll be broadcasting live this summer with my friend Bubba. Bubba is the keyword or password for March, and we'll be going down there together. He'll be speaking on behalf of Memorial Hermann's ACL rehab protocol, and then I'll be broadcasting all that stuff live. And then, are you speaking at the sports medicine update this summer?
Yes.
Yes, you are. All right. So for Bob Marley, super generous. He always lets me come out, or last 2-3 years I've been able to come out and interview and record those sessions and use them here on the podcast. So I definitely recommend, if you're in or around Houston this summer, which is June 13th and 14th this year, check out the sports medicine update. It's a really good workshop. It's easy for, actually, when I was going to interview Dr. Ott at the session, somebody had to go grab her from the 3 conversations she was having and bring her into the interview room so that, you know, she didn't spend all afternoon talking, because that's the kind of environment it is. So I really, really enjoy the sports medicine update there from Memorial Hermann. And if you want to get a hold of me, my website, sportsmedicinebroadcast.com, where March is NATM, sportsmedicinebroadcast.com/NATM. So that's National Athletic Training Month, which is coming up in March. We got a lot of stuff podcasting just about every day. So I have 15 episodes over the course of March with the spring break included there. Twitter, I'm at PHS Sports Med. Dr. Ott is at OTT Summer. And then the website for this episode is sportsmedicinebroadcast.com/Dr. Dr. Ott, OTT, DROTT. So for Jeremy and Dr. Ott, Chris Shields, that is a wrap. All right, it's still live. So
I think we both have 1:30.